Good morning to everybody. My name is P.Priyadarshini from Sri Balaji College of Nursing. I'm working as a associate professor in obstetric and gynecological nursing department. Today we'll see about the topic on postpartum hemorrhage. So now we'll see about the introduction. So this PPH, that is the postpartum hemorrhage, is one of the leading cause of maternal mortality in India. All women who carry a pregnancy beyond 20 weeks gestation are at risk of PPH and its sequel. Although maternal mortality rates have declined greatly in the developed world, this PPH remains a leading cause of maternal mortality elsewhere. And coming to the incidence, PPH, according to this PPH, it suggested, national statistics suggested that approximately 11.4% of these deaths are caused by postpartum hemorrhage. In industrial countries, PPH usually ranks in the top 3 causes of maternal mortality. According to WHO, that is World Health Organization, its statistics suggested that 60% of maternal deaths are in developing countries are due to postpartum hemorrhage, accounting for more than 1 lakh deaths of maternal deaths per year. Now we'll see about the clinical definition of for postpartum hemorrhage. Any bleeding from or into the genital tract following birth of the baby up to the end of the puerperium, which adversely affects the general condition of the patient, evidenced by rise in pulse rate and falling blood pressure, is called as postpartum hemorrhage. The end of puerperium. So when we say that is the puerperium and when is the end of puerperium? Previously, it was considered as 6 weeks following the birth of the child is called as the puerperium period or puerperium. Now it has been extended up to 12 weeks following the birth of the child. Okay, now we'll see about the quantitative definition. So quantitative in amount. So when we call that the mother is undergoing PPH or she is under PPH in terms of amount of blood loss. So when the amount of blood loss is more than 500 ml following vaginal birth of the baby is called as PPH, or else when the amount of bleeding exceeds of more than 1000 ml of blood after cesarean section is called as postpartum hemorrhage. So this quantitative definition was given by or taken from WHO, that is World Health Organization. How much time do we have? It is estimated that if untreated, death occurs on average in 2 hours from postpartum hemorrhage, 12 hours from antepartum hemorrhage, 2 days from obstructed labor, and 6 days from infection. So these are the timed, how much of time does be if the mother is untreated, the mother will go for death. So these are the time limit. Now we'll see about the types of PPH, types of postpartum hemorrhage. So there are 2 types of postpartum hemorrhage. First one is primary PPH and secondary is and second one is secondary PPH. So first we'll see about the primary postpartum hemorrhage. So when we call the mother is under primary PPH is within first 24 hours of delivery of the baby, the mother is going for excessive bleeding. It is called as primary postpartum hemorrhage. So under primary PPH, there are 2 types. So first one is third stage bleeding and the second one is true primary PPH. So what do you mean by third stage bleeding? When the bleeding occurs during the separation of placenta is called as the third stage bleeding. And next one is true PPH. True primary PPH is that the bleeding occurs after the delivery of the placenta is called as true primary PPH. So these are the types under primary postpartum hemorrhage. Now, if the bleeding occurs beyond the first 24 hours and up to 12 weeks, or some may say up to 6 weeks, so these term is called as secondary PPH. So within first 24 hours, the mothers are having a severe bleeding, it is called as primary PPH. And if the mothers have excessive bleeding beyond the first 24 hours and up to 12 weeks, it is called as secondary PPH. Next, what are the causes of primary? What are the causes of postpartum hemorrhage? So it mainly depends upon the 4 T's. So first one is tonicity, trauma, tissue, and thromboplastin. So these 4 T's are responsible for the mother to cause postpartum hemorrhage. So first one is tonicity, that is atonic postpartum hemorrhage, and it is most common, and around 75 to 90% of death occurs because of the atonic uterus. This is the most common cause of postpartum hemorrhage. The second T is the trauma. So trauma means any injuries around the uterus. So traumatic postpartum hemorrhage, and this accounts about 10 to 20% of the death of the mother during the time of puerperium. And the third T is the tissue. Any tissues, any retained tissues related to postpartum hemorrhage, in case of any retained placenta or retained bits of membranes has been left in the uterus, it leads to severe bleeding for the mother. So this is third T is the tissues. And the fourth T is the thromboplastin. So coagulation defect related postpartum hemorrhage. So these are the 4 T's: tonicity, trauma, tissue, and thromboplastin. So these are the 4 T's which have been responsible for causing PPH for the mother. Okay. So now we'll see about the risk factors for atonic uterus or atonic postpartum hemorrhage. So why the uterus is not contracted? Why it is atonic? It is because of, one is over distended uterus in case of multiple pregnancy, or in case of hydromias, polyhydromias, when the amniotic fluid has been excess of more than 2000 ml of amniotic fluid, so it leads to over distend of uterus. So that distend of uterus may lead to atonic of the atonic uterus. The second one is mismanaged third stage of labor, and third thing is because of multiparity, and because of anemia and malnutrition, the mother will have, the mother is prone for atonic uterus. And the next risk factor is because of prolonged labor or precipitate labor, the uterus goes for atonic. And APH, that is antepartum hemorrhage. And the next risk factors is abnormal uterine and anatomy. That is because in case of any malformations, or in case of any fibroids, in case of any cyst, the uterus can't able to contract well and it remains atonicity, and this leads to severe bleeding. And the next risk factor is obesity. The mother is obese and loose flaccid muscles also sometimes leads to atonic of the uterus. And next risk factor is the drugs like halothane and tocolitis also leads to atonic of the uterus. And prior history of atonic PPH, postpartum hemorrhage. The mother has been previously prone for any postpartum hemorrhage in previous delivery, the mother has been likely to come under the risk of PPH during the current deliveries. Next, what are the risk factors for traumatic PPH, traumatic postpartum hemorrhage? So the traumatic PPH leads bleeding because of laceration of the cervix, vagina, perineum, and periurethral tear, mostly in instrumental delivery. In case of any forceps or in case of any vacuum, sometimes any traumas at all leads to severe bleeding in the uterus, and and also any complicated vaginal delivery also leads to unexpected blood loss. And then next traumatic is because of ruptured uterus and extension of the cesarean section incision and uterine artery tears. And the next risk of traumatic is a broad ligament hematoma and uterine inversion. Okay. So what are the management of primary postpartum hemorrhage? So there are two components. So first one is the prevention. So we have to prevent. And next one is the treatment. So these are the two baseline management of postpartum hemorrhage. So one is prevention and the other is treatment. Prevention. So how we can prevent the mother from getting postpartum hemorrhage? So by regular antenatal care, and by correction of anemia and malnutrition, and we have to identify the risk women and deliver them in a hospital where emergency obstetric care, that is EMOC facilities, have been available, and we can able to prevent the PPH by emergency referral facilities to a tertiary care hospital should be available, and the routine active management of third stage of labor. So this is very, very important in preventing the mother to undergo postpartum hemorrhage. So these are the basic criteria which helps the mother in from maternal mortality rates. What do you mean? What is AMTSL? It is the active management of third stage of labor. So it is recommended by WHO that active management of third stage of labor should be done in all cases. It should be done it should be done for all the pregnant mothers. Why it is necessary? Because it minimizes the blood loss. It cuts short the third stage of labor. So because of two essential things, this active management is very, very important. It's been recommended by the WHO. So it should be implemented to all the mothers who have been undergoing these deliveries. So WHO recommends for active management of third stage of labor in the year 2012. How in check the uterus for presence of twins. Uterotonic drugs should be given immediately after the delivery of the baby in all the births. And we have to delay cord clamping and control cord traction. This CCT, that is control cord traction, is not mandatory. It can be performed if required. And we have to maintain a postpartum vigilance for uterine tonus. So these are the recommendations given by WHO for active management of third stage of labor. So uterotonic drug should be given immediately after the delivery of the baby in all births. So what is the use of this uterotonic drugs? The use of uterotonic drugs is for the prevention of postpartum hemorrhage during the third stage of labor. Is recommended for all type of births. For example, the drug oxytocin should be administered, should be given at 10 international units, that is by through IV or through IM. That is recommended, oxytocin is the recommended uterotonic drugs for the prevention of PPH. And other option is also misoprostol. So ensure that a continuous supply of high quality oxytocin should be maintained through the cool chain. So this is very, very important. Okay. Next, what do you mean by delayed cord clamping? So delaying clamping the cord for at least 1 to 3 minutes. It helps in reducing the infant anemia. The rates of infant anemia has been reduced by delaying the clamping of the cord. The only indication for yearly cord clamping in modern days obstetrics, why we have to immediately clamp the cord means in case of the baby is asphyxiated. So in case of asphyxiated baby who needs immediate neonatal resuscitation, so in such types of baby we can go for immediate clamping the cord, or else if the baby, the health of the baby is stable means we can go for delayed cord clamping for minimum of 1 to 3 minutes. So by delaying the cord clamping, we can able to reduce the rates of infant anemia. CCT, that is control cord traction, is not mandatory. We have to perform CCT when is required, if required, in which condition. In settings where skilled birth attendants are available, control cord traction is recommended for vaginal birth. In settings where skilled birth attendants are unavailable, we mustn't recommend this control cord traction. So this control cord traction is the recommended method for removal of placenta in case of cesarean section. Next is the postpartum vigilance for uterine tonus. Immediately, we have to assess the uterine tone to assure the uterus is contracted. We have to continue to check every 15 minutes. For every 2 hours, we have to continuously monitor whether the uterus is going for a contraction or not. So this should be checked for every 15 minutes. Up to 2 hours, we have to watch continuously for the contraction of the uterus. If there is a uterine atony, perform the fundal massage and monitor more frequently. But sustained uterine massage is not recommended as an intervention to prevent PPH in women who have received prophylactic oxytocin. Treatment for PPH. So the main treatment of PPH, so how we have to prevent, how we have to treat. So it is by medical management and by surgical management. So that is hemostasis. So hemo comes under medical management and stasis comes under the surgical management. So we'll see one by one. So coming to the medical management, that is hemostasis. So hemo, that is HAEMO. So we'll see the, so H stands for help. Ask for help, just shout, just ask for the assistance for the help, that is H. A for assist assessing the vital signs, blood loss, and resuscitation. These are the things which should be assessed. And E stands for etiology and also ensure the availability of the blood. And M stands for the massaging the uterus. And O stands for the oxytocin or oxytocic drugs. So this is about the hemo. It is H for help and A for assess and E for etiology, M for massage and O for oxytocin drugs or oxytoxics. Next is the stasis. So stasis stand, that is, we'll see the abbreviation. So S stands for shift to OT. OT means operation theatre. We have to immediately shift the patient for the operation theatre. And T for trauma, to exclude tamponade. And A, we have to apply compression sutures. And S stands for stepwise pelvic devascularization. And I stands for intervention radiology. And S stands for subtotal hysterectomy. So this is about the stasis, the shift, trauma, apply compression sutures, and S stands for stepwise pelvic devascularization and interventional radiology and subtotal hysterectomy. Okay, H. Now we'll see one by one. H. The first thing is H. That is H stands for help. Ask for help. Whenever the mother is PPH, the first and foremost thing is to shout for help. It is a teamwork, not only a one man's job. So just to call assistance and just shout to acquire the help from the other people. And A stands for assess. So we have to assess the vitals, blood loss, and resuscitate. So we have to monitor the vitals. So pulse, BP, temperature, respiration, and oxygen saturation should be monitored, and put the patient on the multi-parameter monitor. This is very, very essential. Resuscitate. Make 2 intravenous channel with the large bore cannula, that is 18 gauge, in both hands, and insert IV fluids, start IV fluids, that is crystalloids, ringalactrate, and colloids, to be given till the blood is available. Then most oxygen at the rate of 10 to 15 liters per minute, and catheterize to monitor urine output. E. Establish the etiology. So we have to assess what is the cause of this atonic. Any retained bits of placenta, any retained bits of membranes have been. So we have to assess the uterus tone, whether it is atonic. And then we have to go for the local examination to exclude any trauma on the cervix, any trauma on the os, any trauma on the vagina. So we have to, any trauma on the uterus, we have to assess for the local examination for any traumas being present. And next we have the examination of the placenta and membranes to exclude any retained bits. And investigation, complete hemogram, coagulation profile, electrolytes, blood, and grouping. Ensure availability of blood. Immediately send blood for grouping and cross matching, and arrange for at least 2 units of whole blood. So this is very, very important. Oxytocics. So start oxytocin infusion at the rate of 10 units in 500 ml of normal saline at the rate of 15 to 30 drops per minute. And the other option of drug is methogen, that is methyl ergometrin. So the dosage is 0.2 milligram, may be given IV intravenously. Oxytocics. So the drug of choice is oxytocin infusion. The dosage is 10 units in 500 ml of normal saline at 50 to 30 drops per minute, and it and should not be given when it is contraindicated. The patient has a heart failure. The other drug of choice is methogen, that is methyl ergometrin. So 0.2 milligram may be given IV, and repeat after 15 minutes. Maximum 4 doses can be given. So and it should be contraindicated if the patient is having hypertension. And next drug of choice is carboprost, that is 250 microgram intramuscularly given, and repeat after 15 minutes. Maximum 8 doses can be given, and it should be contraindicated if the patient has any complaints of asthma. And the fourth drug of choice is misoprostol. So it is a tablet form, 200 microgram sublingually, or per rectal also it is being given. Usual doses 600 microgram. So there is no specific contraindication for misoprostol. The next drug of choice is tranexamic acid, tranexamic acid. So it is given in the form of IV injection. 500 to 1000 milligram can be repeatedly given for every 4 hours. So there is also no contraindicated for this tranexamic acid drug of choice. Next, S stands for shift to OT, shift the mother to operation theatre. So while shifting the patient, the following things may be done. So we have to go for bimanual compression of the uterus and NSAG, that is non-pneumatic anti-shock garments. This is very, very important, and nowadays the PHCs have been following to arrest or control from shock. So this anti-shock garments have been provided in all PHCs to arrest the shock which has been encountered because of PPH. So this is the bimanual compression of the uterus. So we have just insert the right hand into the uterus and just hold by the help of your left hand, just hold the fundus of the uterus tightly and just give a compression slowly and steadily. So this, by giving this compression, we can able to arrest or control the bleeding because of from PPH. And this is the non-pneumatic anti-shock garments. This is available in all primary health centers. So this is also non-pneumatic anti-shock garments. Okay. Now is the trauma. So if any trauma is noted, it should be immediately repaired by using the tamponade. So there are have been many varieties of tamponade, that is Bakri balloon and Sengeston Blakemore tube, Rouge balloon, Foley's catheter, or uterus can be packed with gauze. So these are the tamponade which has been helps in preventing or controlling the bleeding from PPH. So this is internal uterine tamponade, this Bakri balloon. And this one is Sengstaken Blakemore tube. And this is the Foley's catheter and Rouge balloon, which can help in preventing the bleeding. So, and this is the packing of gauze into the in the uterine cavity. So by this, keeping the pack in the uterine cavity helps in controlling the bleeding. And there's apply compression suture, that is by B. Lynch, modified B. Lynch, and co-sutures. So these are three things, compression sutures. So this is the B. Lynch braid suture. And this is the co-sutures. Okay. Next is this S stands for stepwise pelvic devascularization. So this includes the uterine artery ligation, ligation of round ligaments, and internal iliac, that is the hypogastric artery ligation. So these are the stepwise pelvic devascularization. So we'll see. So this is the uterine artery ligation. So this is the hypogastric artery ligation. And I stands for interventional radiology. So this is very selective. Uterine artery or the internal iliac artery will go embolization of with the help of angiographically guided techniques. So this is the embolization of the left internal iliac is being done. And S stands for subtotal hysterectomy. Last resort, if everything fails, sometimes total hysterectomy is also done. Ovaries must be preserved at any cost. Okay. Rule of 30. So if the systolic blood pressure drops by 30 mmHg, or if the heart rate falls by 30 beats per minute, or if the respiratory rate becomes more than 30 beats per minute, or the hematocrit or hemoglobin drops by 30%, or the urinary output becomes less than 30 ml per hour, is very, very crucial period. It means that the patient has lost of about more than 30% of her blood and she is in moderate shock. So we should be very, very cautious. So sometimes the complication and all the morbidity from PPH, because of all such things, the mother can be very severe with sequel, including the mother can go for a severe organ failure, she may go for shock, edema, compartment syndrome, transfusion complication, thrombosis, acute respiratory distress syndrome, sepsis, anemia, She may also undergo intensive care and prolonged hospitalization. So these are the major complications if the mother is undergoing postpartum hemorrhage. So the golden hour is very, very important. And when we say that is a golden hour, that is the first hour of PPH, that is the first hour of postpartum hemorrhage is taken as the golden hour, because if management started within 1 hour of onset of PPH, then the patient can be the best survival rate. Okay, we can able to save the life of the patient within the first hours. That is the first hour is very, very crucial and very important golden hour during her labor time. So within that first hour, we can do so much of miracles. We can able to save the mother's life, and the chance of survival decreases sharply after the 1 hour. So we have to have a crucial active management of the stage of labor is very important to save the mother's life. So, coming to the conclusion, this postpartum hemorrhage is the leading cause of maternal mortality and morbidity rate. In order to prevent these fatal diseases, it is very essential to accurately assess the risk factors and also arrest the blood loss during the delivery. And also one of the most recommended thing according to WHO, the active third stage of labor is very, very important to save the life of the mother. Thank you.